Good afternoon, everyone. Thanks for joining us today for our live question and answer presentation. My name is Arpan Patel. I'm the Director of Pain and Spine Center here at Edgerton Hospital. Really excited about doing this type of forum. Haven't had a chance to do this before, so really excited, and kind of like just having an informal consultation with me without having to come and see us. We've got a lot of people that have presented some questions, and I'm going to just kind of have our team read those questions off and answer them to my best ability. And we'll keep taking questions. Hopefully people are on here and you can always engage with us and chat with us and send us information or follow-up questions that maybe might be able to answer for you guys.
So I will be the voice and not the face today. I'm Jason in marketing here, and I will have the priority of reading the questions for Dr. Patel that were submitted in advance. We had a number of them. If you would like to submit a question, either in Facebook or YouTube, during the live, that will come up in the comments and we can address those questions too. So Dr. Patel, our first question today was from Rachel. Rachel says, what is your approach when working with patients?
Great question, Rachel. So every time we see a new patient, we do a kind of a background kind of assessment of finding out information from their prior history, from their past medical, from their primary care doctor. Maybe you've seen an orthopedist, or maybe you've seen a neurosurgeon. All that information we try to capture so that we have a full kind of overview of your care and how I can maybe add to that. We also try to pull as many imaging results that we can, so that way we're not duplicating things that you've probably already had. When you do come to see us, we have a consultation and we do a full exam, kind of go over all your past medical history, your medications, any kind of procedures you may have had, surgical history, and then we'll sit down and discuss kind of options that may be available. I'm an interventionalist, so my background is pain management and anesthesiology, but with a fellowship in interventional pain management. So my goal is to try to give options for minimally invasive procedures like injections or minimally invasive surgeries as a very easy treatment option for you that doesn't take a long time for post-operative care that may provide you relief from pain. And at the same time, we're also going to talk about other avenues of pain management, including physical therapy, behavioral modification, pain psychology, medication management, all these things, holistic care. All these different things also play a huge part in our treatment for pain. There's not one quick answer for treating someone with chronic pain or even acute pain. And so we look at all the different facets that are available. But in the end, we'll come up with a game plan. And from that, as a team, we'll work together to see if we can alleviate some of your pain and get you back to functioning normally.
All right, Dr. Patel, Brenda is wondering, how can you help low back or sciatic pain? A lot of people suffer with low back pain.
Yes, so Brenda, that is probably the most common thing that we see here. 80%, maybe about 75 to 80% of our patients that come to see us are suffering from back pain. And my background also in fellowship, spine is kind of the focus of our interventional treatment. We also treat, neck pain, headaches, nerve pain, complex regional pain syndrome, foot pain, joint pain, hip pain, knee pain. All these things are treated, but low back pain is quite the big one that we see all the time. So with low back pain, the most common sources of low back pain usually are, we call that myofascial or muscular skeletal. Lumbar sprains encompass about 70% of low back pain visits to the ER as well as to us. And the funny thing about sprains is that you think that they would just go away within a couple of weeks, but a lot of times these things can be lasting 3 months or even longer. And there's treatment for that. For sprains and muscle spasms and things like that, we do something called trigger point injections associated with physical therapy. That's a quick injection that we do into the muscle groups. And the idea is that we're causing a little bit of inflammation while we stick the needle into the muscle groups. And I always tell patients, think about a piece of meat. If you're sticking a fork in a piece of meat, it tenderizes it. And so basically the idea is that we're pushing little needles into the muscle fibers, and then you go home and try to pull and stretch those muscle fibers out. And then your body will naturally heal, hopefully in a kind of relaxed fashion, so those spasms can go away. And we do that over a course of a couple of series of those injections with physical therapy. Moving on to the next most common source for back pain, and I'm going to stand up here just to kind of use some of these models so I can explain this. I'm going to spend a little time here on this low back thing because it's honestly the most common thing that people come and see us with. So I'm just going to go over kind of different etiologies or sources of pain from your back. So the first thing going from out to in was the muscles, the ligaments, the tendons, and that's, the majority of where patients are suffering from pain. Those ligaments and muscles in the back attach from the spine here, but also go all the way out to the muscles of your upper back and your buttocks as well. So many patients suffer from inflammation along the crest here where, you feel like you have butt pain. And that's because the attachment of the muscles of your buttocks attached to the iliac crest here, and as well as there's ligaments that are attaching from the lumbar spine and the sacrum to your ilium. And all these things can get stretched and strained and get inflamed. And so for those kind of things, we do those simple trigger point injections. We also do some nerve blocks. They're called cluneal nerve blocks that can be done to help you with buttock pain. But that's the outside part. As we go deeper, people that are just suffering from back pain and not really leg stuff, those patients may have either a disc origin of pain, such as like a tear in your disc, or more commonly, you can have arthritis of these joints in the back of the spine called facet joints. Those patients usually have more pain when you're bending backwards as opposed to bending forward. People bending forward having more pain, it's usually stretching of the muscles, or it could be disc related too. But treatment for these joints here, we can do different kinds of injections, some with steroid and some that actually last a lot longer. It's called radiofrequency ablation, where we can actually burn the little nerves that go from the big nerves here, which are these yellow lumbar roots. These little nerves called medial branches, they wrap around the bone here and then go into each individual facet joint. So the way I think about it is when you go to your dentist and they do a lidocaine injection in your mouth that numbs up the tooth, the idea is that we also do the same thing where we numb up the nerve that goes to the individual joint, the facet joint. And so when we do that, theoretically, you shouldn't have any pain if your pain is stemming from those facet joints. If you get two positive diagnostic tests, then we can come back and do an ablation where we have a different type of needle that has an electrical heat generator, and it burns the little nerve, cauterizes in a sense. It can modulate the nerve and basically kill the nerve for a short period of time, and it does grow back. But the results can last for about a year, sometimes longer, and the nerves grow back, and then if pain comes back, we can do another ablation. So that's for the facet joints. I think the question was for sciatica. That's also very, very common. Usually that's more commonly due to disc issues, disc herniation. So this is the front part of your spine, and this is the back part of your spine. A lot of patients will have some sort of pressure, like this is showing here. When you press forward, this disc can push outwards and cause, like we hear, herniations or extrusions or protrusions. All these things just mean that this little jelly donut is what I think of it as. The jelly is trying to push outwards and it's causing compression on the nerve here. And those nerves go down into your legs. So what we do for that, the simple treatment for that is epidural steroid injections. Very common procedure that we do. Takes about 5 minutes for me to do an epidural injection. We do it under live X-ray fluoroscopic guidance. And just I'll backtrack there. Every one of our procedures are done with some sort of guidance. So any injection that we do will have some sort of imaging involved. So that way there's no error associated in actually getting into the space. So even trigger point injections, I use ultrasound. For facet joints, we use the fluoroscope. For these, we use a fluoroscope or X-ray too. For all joint injections, for knees, shoulders, hips, all of that is done under guidance, either ultrasound or fluoroscopy. So everything we get, we want to make sure and get the medicine in the space that we want to target, because that's the whole point of this, is get as close as we can, do the smallest amount of medication as well as incisions as well. So anyway, for epidural steroid injections, that can give you significant pain relief, lasting sometimes years, but from a standpoint of normal distribution, about 3 to 6 months is where the sweet spot is for most patients. But again, if your herniation is mild and the disc reduces in size, you can just get rid of the inflammation by putting the steroid there, and you can have lasting relief from that. And with these injections, you can have repeat injections safely. We try to limit the amount of steroid dose you get, but it's individualized. So the patients, we'll have a discussion about how many you can probably get per year and things like that. But definitely a great option for treatment for that.
So Dr. Patel, if you could, I'm going to zoom in on that.
Yeah.
Cecilia just wanted to know what that was you're holding again. If you could just kind of just talk through
Absolutely.
the model again.
This is, do you get it?
Yep.
So this is your lumbar vertebrae here. It's a bigger version of what we see here. So basically, the red that you see here is the discs in between the vertebrae, and this is your bone, the vertebrae above and below. So in between is your shock absorbers. So these discs, and you probably heard of like disc herniations, or I've had a disc bulge. These are the little jelly donuts in between. So these little red things here, those are our shock absorbers. As we get older, the buoyancy of these discs reduce, and you get the kind of a pancake. If you think of a donut, basically, if you squeeze the donut down, it turns kind of a pancake, but if there's jelly inside, the jelly has to go somewhere. So that's what happens when you push down on the disc. You can actually see that the disc can herniate, and the pressure causes the jelly from the inside to pop out, and it pops out backwards, and that's where the spinal cord is. So the yellow in the middle is our spinal cord, and the nerves come out of there and they go down your legs, or if it's in your neck, it goes down into your arms. So everything I talk about in the low back also applies to the neck. With sciatica type symptoms in the neck, they occur in your arm. So you'll have numbness, tingling, burning pain down your arm into your fingers. That's if you have a disc herniation in your neck. If you have one in your upper back and your thoracic spine, it'll go into your chest wall. So you'll feel burning pain kind of going into your abdomen or your chest. But all these things apply from the top to bottom of our spine.
All right, thank you for that. We also had a question earlier just about phantom pain.
Yep.
If we deal with phantom pain much.
We do. So phantom pain is another very common kind of things that we see. This type of pain we call that central pain because, once the nerve is cut, obviously there's no longer an appendage associated to the area that person's feeling pain. So what happens is that there is a modulation or change in our brain that occurs when a nerve is cut. And our brain is then perceiving pain to be there when there actually is no limb there. So treatment for that, one of the most common treatments that we do for phantom limb pain is nerve stimulation. So I was going to talk about that later, but this applies for limb pain as well too. So a spinal cord stimulator is a device that we implant into the spine. It's a minimally invasive procedure. Incisions are very small. We place an electrode or a couple of electrodes that are up top here. This is where the electrodes stimulate we call it the dorsal column or the back part of your spine. So let's say you're having phantom limb pain down into the leg and the knee. We can place these electrodes in the area where those nerves originate and kind of zap the back part of the spine and change the way that your brain perceives the pain. So the burning type of pain that you're getting, that can be reduced, or depending on the type of spinal cord stimulator we use, we can make it change to make it maybe a buzz sensation or vibration, different things like that. The beauty of these procedures is that you get to do a trial first. So you can have a procedure done, you take it home for 5 to 7 days. You have a little remote control that you can use to change the parameters of what you feel. And then if it works for you, meaning that you get 75 or 80% significant improvement in your pain, then we actually implant it. So the beauty of that is that there's no incisions, there's no surgery until you actually see that it works for you. And there's really good studies and data on that for phantom limb pain. But since I'm on this topic, it also works, it's FDA approved for patients that have had continued back pain and leg pain after surgery. So if you've had spine surgery, and the diagnosis is actually called failed back surgery syndrome or post-laminectomy syndrome, that's approved. So insurance covers it, Medicare, Medicaid, all that covers that. So that's an option for patients to have a simulator placed if you still continue to have back pain after surgery. And it is very common to have back pain after surgery. It's not always indicated because obviously there could be something going on that we need to address after surgery that's new. But a lot of times scar tissue and other factors that come in after surgery continue to cause pain. And so this is a really good option for patients that have continued back pain from both surgery or even for phantom limb pain, complex regional pain syndrome, which is something that I'm not sure if anybody's going to talk about here, but that's another FDA-approved indication, as well as diabetic neuropathy. So anybody with diabetic neuropathy can have a stimulator placed with significant improvement of pain in their legs just from having this device placed. So it's something to really consider. If you want more information, come by and see us, and we can just have a discussion about that. And that way, you can kind of see whether it fits for you.
All right. Gina is wondering, she said, I recently fractured my arm. Is there anything I can do for my pain?
Yeah, Gina, that's a tough one. I don't know exactly how long you fractured it. If it's a recent fracture, obviously we have to wait for it to heal. Just the normal casting and time. Pain medications in that situation is appropriate. So we are, as a pain management physician, we are not necessarily anti-medications. Everyone, right now with this opiate crisis going on, everyone thinks that, as a pain management doctor, we're gonna, kind of give out opiate medications. We can and we do for certain situations, and this is a good situation. If you have an acute fracture, no problem. But it's the long-term management of chronic back pain, chronic overall muscle pain like fibromyalgia or chronic pain syndrome. Those conditions do not get better with opiates, and in fact, they actually progress to get worse. Studies after studies have shown that the quality of life index deteriorates with more and more chronic use of opiates. In fact, you can actually have worsening pain. It's called opiate-induced hyperalgesia with chronic use of opiates, and it also worsens depression, anxiety, all sorts of other things, along with the side effects of normal opiates. So we're not a big proponent of using opiates in our regular care, but in an acute fracture situation, you can. Now, if your fracture is chronic, that's where that complex regional pain syndrome that I spoke about might be something that could be occurring. It's a disease that occurs, and it's not well understood, but it occurs in patients that have had fractures or trauma to a distal or an extremity, and you start seeing changes occur in those extremities, such as swelling, changes in sensitivity, like you touch your skin and it's on fire. You have loss of motor strength, you have sweating changes, your hair starts growing differently in the arms, skin starts having lesions and rashes. All these things are part of this syndrome. So I don't know if you have that or not, but that's also something that we do treat. Yeah.
Thank you. Okay, Dr. Patel, we are going to move next to knees. So Barry said, I have horrible knee pain and have had steroid injections, but that's not helping. Is there anything else that can help?
Yes, so great question. For knee pain, so the most common thing that we do for knee pain is steroid injections. That's probably the first line treatment for somebody outside of physical therapy, right? You have knee pain, you have arthritis. We definitely recommend physical therapy, an anti-inflammatory medication like ibuprofen or long-acting types of NSAIDs, rest, ice, elevation, all these things are what we do initially for knee pain. After that, if you're still having significant pain, we'll do an injection where we can put steroid into the capsule of the knee, and that can help reduce inflammation in the actual knee. If that doesn't work, the next step is an injection with what we call viscosupplementation, or a kind of gel. It was first derived from rooster combs, like the comb that you see on the top of roosters. That molecule actually stimulates the chondrocytes or the cells of our cartilage to produce more of the lubricant in our knee. So it actually can lubricate the knee and also serves to have an anti-inflammatory purpose, just like corticosteroids do. So there's multiple types of different types of those viscosupplementations. We can talk about different properties of each one, but in general, they're a form of hyaluronic acid, and we put it in there, and that can actually give you longer relief than steroids. Steroids usually 3 to 6 months, whereas the viscosupplementation gets 6 months and even greater. And it's approved by Medicare and all other insurances as well. So that's the second step. The third thing, if you're still having knee pain and you're really not sure you want to have surgery, or you can't have surgery because maybe you have too many other comorbidities or other diseases that preclude you from having surgery, there are types of nerves called genicular nerves that run alongside your bones in your legs. And we can go and place needles over those nerves and ablate those nerves using radio frequency. So there's many genicular nerves, and we try to capture as many of them as you can. So basically with our procedure, we'll come in from the front, from both sides here, as well as off to the side here, and we'll do lesions on the side of your knee to target the nerves that actually go into the joint. So you can have repeat ablations done, and that can last years, of relief. So that's a simple outpatient procedure that we do for knee pain. And then let's say those don't work, or you're not having as long relief as you want, because obviously there are only certain areas that I can burn, but there's multiple other nerves that are going to the knee. So after that, there's another device called peripheral nerve stimulator. And these devices, I don't know if you can see this or not, but these devices can be placed anywhere that there's really nerves that we want to target. And for the knee, we would place a lead right here on the femoral nerve, the saphenous nerve, and we do this with ultrasound. So we just take this little probe inside of this little pen, and we put it with ultrasound guidance. I'll direct this lead on top of the nerve. Once we get it on top of the nerve, we attach it to a little device on the outside of your skin, and you plug this little module or the battery pack on top of the little nerve, and this gets stimulated for 60 days. So the treatment for peripheral nerve stimulation, this one is not a permanent type. There's also permanent peripheral nerve stimulators, but this is a kind of a newer product that's been out with great studies, about 70% improvement in all chronic conditions, treating even headaches, occipital headaches, treating neck pain, back pain of all varieties, as well as knee pain, foot and ankle pain as well, and shoulder pain. So all these things can be treated by this simple device that goes in, no incisions, and you wear it for 60 days. The only caveat to that is we do have to replace the little skin pad every 7 days. So there is a little bit of kind of work at home, but you want to keep this on, and it stimulates the nerve. And over the course of those 60 days, 70% improvement for up to 1 year to 2 years of relief. So that's strong studies that show that this is an effective device. And it's something that we offer patients for all sorts of different conditions in our bodies.
Right. So a number of people also deal with migraines. And Sophia says, I suffer with terrible migraines. What things can be done to help me?
Sure. So migraine headaches, along with other types of headaches, is something we see, again, very commonly. Usually a neurologist is managing some of the medications for migraines, and many times they'll send us their patients for more of the interventional things that we can do. So something that's kind of come up relatively new, when I say relatively new, I would say probably 10 years or 5 years or so, is Botox for migraines. And you have to have the diagnosis of chronic daily migraine headaches, which is basically having headaches occurring for greater than 4 hours a day for 15 days out of the month. And you've had to try a lot of the different medications and different other options that are available for you, for insurance to cover it. But it definitely works. And it's a simple Botox injections, 31 little tiny spots all around your head. And it works in multiple ways. It's not just relaxing the muscles in your head. It actually works on a neurochemical physiology, but significant improvement, 3 months of reduction of headaches, and you can have these Botox injections every 3 months once you get effectiveness from them. And the nice thing about it, which is a side effect, is that your wrinkles are removed too, just as a side, but that happens. So that's one thing. The other thing is if you have migraines that are coming more on the back of your head, so when we look at a lot of patients that have migraines, sometimes the headaches are actually in the back of the neck going into the top of the head. And this is a very common area we'll call occipital headaches, or even cervicogenic headaches. Those headaches can be treated by doing simple injections where we knock out the little nerves that go to the back of the head. They're called occipital nerves. You can have occipital nerve blocks to help relieve the pain in your head here. If your headache is more in the front here, we can do supraorbital blocks on the top in front of your eyes to capture the frontal part of your head. If you have like headaches on the side of your head, there are nerve blocks as well as Botox can be done for, like, for example, TMJ. That's a treatment that we can do, although that one is not necessarily covered by insurance, but it is still an effective treatment for TMJ. And then also the peripheral nerve stimulator that I just spoke about. They can be placed right in the back of the head, here in the neck, and we target the occipital nerves in the back of your head. We could place those there, and you'd have a treatment for that. And then we can burn nerves. So instead of, let me show you, instead of targeting the occipital nerve up top here, where we would block the occipital nerves, instead we would go into the spine area here, and we'd knock out the third occipital nerve, which then becomes part of the occipital nerves that go to your head. So I can do an ablation where I can burn the nerves, and then you can get, a year of relief from these headaches. And then if the headaches come back, you just do the ablation again. But these are all minimally invasive, less than 30-minute procedures that can be done to help alleviate your pain and get you more comfortable.
Michelle writes in, or sent in a question earlier asking, she said, I have numbness in my fingers. What could it be from? What could be causing that?
Sure. So Michelle, yeah, numbness is one of the common kind of symptoms that a lot of people come, spasms, as well, associated with burning type pain and numbness. Usually with numbness in your fingers, we look at two different major etiologies or causes. One, if it's these 3 digits that are causing the numbness, we think about carpal tunnel. So your median nerve comes through here, overlying the carpal tunnel, or where the fascia lies, and that can be entrapped, and that causes nerve irritation in the hands. If it's the last 2 digits of your hand, those two can be coming from your ulnar nerve, which is at your elbow, and it can get entrapped there. And then more commonly, or maybe about the same amount of frequency, you can actually have nerve pinching occurring in the neck. So you can have a disc herniation, or the narrowing of the hole where the nerves come out of your neck, which is called a foramina. So a lot of people can have like stenosis and narrowing of where the nerves come out, and that also causes numbness. So a good way to figure out where it's coming from outside of just doing an exam would be to get a nerve study done, like an EMG or nerve conduction velocity test. And then that would help us kind of pinpoint, is your entrapment occurring in your wrist? Is it coming in your elbow? Is it coming from the neck? We also get MRIs of your neck to help us figure out if there's an active disc or something pressing on the nerves that go to your hands. Medication management can be done for treatment for numbness, and then also simple injections into the areas that are being entrapped. So if you have carpal tunnel issue, we could try a little steroid injection at the level of the entrapment. And the steroids, what they do is they reduce inflammation and open up the space in the area. So if your nerve is being compressed, that could be an option. If it is carpal tunnel, we also recommend a splint. It's called a cock-up splint, and we would wear that at night as long as with some therapy as well. And for your neck, simple epidural injection for your neck can help as well, if that's what the source of the numbness is.
All right. Kathy sent in this. She said, I still have pain in my right breast underarm due to lumpectomy, lymph node removal, and then 28 rounds of radiation. Is there anything I could do to lessen the pain?
Yes. So yeah, Kathy, we see radiation-induced neuropathy. That's what normally happens after radiation. It kills the tumor cells, but at the same time, all the little tiny nerves that you have in the periphery of the breast, they get damaged too. And so a lot of patients end up having nerve pain and burning pain in the breast after surgery and also after radiation therapy. Each one of the nerves, let me show this one. Sorry. Each one of the nerves that go to our body, I don't know if you could see this or not, but each nerve that comes out of your spinal cord, as they come out of your spinal cord, they go to different locations in our body. So the breast and the nipple area is T4, the umbilicus is T10. So just based on where you're feeling your burning type of pain, let's say it's T3, T4, T5, then I know what I should be targeting. So as the nerves come out of your thoracic spine, they then go and wrap around the ribs to they call it intercostal nerves, and those nerves then go to the skin. So we can do blocks where we knock out those nerves that go to your breast and apply a little medication there to help reduce that kind of pain. And let's say the injections, well, the other thing is if the injections don't work, the stimulator that I was talking about, the peripheral nerve stimulator, that's a temporary option that we can do on those nerves. And you can do that for 60 days and that might help. The other thing is the spinal cord stimulator. So these stimulators can be placed for the neck, can be placed in the thoracic area and the lower back. That can be an option for people that have intractable nerve pain. So we do have options for those conditions too.
All right, Mike is here, and Mike, since in the question said, I had a shoulder surgery and the pain is still there. Is there anything I can do for more long-term relief?
Sure. So shoulder pain is definitely a tough one. Obviously, it limits a lot of things that we do. Range of motion is a big thing. So sometimes with the pain, you can't really move your arm. So physical therapy and increasing range of motion, sometimes medications might be needed to help you get that range of motion back. But if you have, like, let's say bursitis or rotator cuff issue, and you don't have an active joint replacement, like a surgery for joint replacement, then we can do injections into the different places. So if you have a rotator cuff injury, I can locate each individual tendon or the bursa there and place steroid there to help remove impingement syndrome or pain from moving your shoulder. Oh, let me show you. So, for example, this is the back part of your shoulder here. This is the front. So these are your rotator cuff tendons that are attaching to your shoulder. So we could do a guided injection if, let's say, your supraspinatus tendon has a fray or inflammation there. We can place medication into the area where it's being entrapped to give you improvement in pain as well as range of motion, just raising your arm. If you have significant arthritis in the joint, you probably already had this since you've had surgery, but we can do injections into the shoulder capsule, just like we would do for the knee. And that can help patients that have arthritic conditions of the shoulder. And then after that, then we start looking at a little bit more invasive things. One being the stimulator, the peripheral nerve stimulator. So there are nerves that go to your shoulder, which is the suprascapular nerve, which is located right here underneath the muscle right here. And then you also have the axillary nerve, which comes out across here there along your humerus. So things that we can do is place electrodes here as well as here. And those electrodes then would capture all the nerves that go into your shoulder. So then after doing the treatment for 60 days, patients end up with significant pain relief for years from shoulder pain, just by putting these little electrodes in and wearing the device for 60 days.
We're going to go back to back pain here, Dr. Patel.
Yeah.
Let's see. We had someone who's noted they've had low back pain for many years, Mary. She says it does not go into her legs, but it hurts worse when she bends backwards.
Okay.
What are your thoughts or what could be done to help?
Absolutely. So, Mary, I touched upon this earlier, but I'll do it again because it is very important. So, like I was talking about earlier, our exam does help us kind of identify what our targets are. MRIs help as well, too, but when we look at the back, there's millions of different things that can cause back pain. We'll talk about this a little bit, but there's structural sources of your pain. So structural meaning pain occurring from some sort of damage occurred in your actual structural body. So inflammation in the joints, infection, tears, disc herniations, fractures, all those things are structural things that can actually cause pain. There's also non-structural pain, which is huge part of chronic pain, and it's a whole different topic, but just so since I brought it up here, chronic pain has both a structural and non-structural component, and the field of neuroscience has been advanced so far with the new functional MRIs, the capability of looking at your brains while you're doing different functions, and we've seen significant evidence showing that patients that suffer from chronic pain for long periods of time, or 6 months or greater, have abnormalities that occur in the brain in many of the processing centers that are in the brain. So a lot of times when we think of pain, it doesn't necessarily have to be coming from the source of your pain. It actually can be stemming from your central nervous system in your brain, and that's called neuroplastic pain. So there's a huge amount of evidence showing that is a large part of our pain that we suffer from. And I know it sounds like, oh, well, when I say this to patients, I always get the thing, well, so you think it's all made up or it's all coming from my brain? That's not what we're saying. We're saying it's real pain that you're suffering from, but the source may not be coming from the back, but it may be coming from the central nervous system and neuroplastic changes that occur there. But let's say it is structural. So if it is structural, then the back bending here, when you're bending backwards, it causes pulling of the muscles in your back. So one thing that when you bend backwards, you have to use your muscles to bend backwards. So strengthening your core muscles in your back can be helpful. Trigger point injections, physical therapy can do that. Now, more commonly, or not more commonly, but other sources deeper is the facet joints. So these are the joints here and here, here, here. They go all the way up your spine. So you can have facet problems in your neck, you can have facet problems in your back. But things that we do for that, the mainstay treatment for arthritis of your spine is radiofrequency ablation. So that's the procedure where I was talking about burning the little nerves that go into your joints. We do that, but before doing that, we do a test first. We actually do 2 tests. They're called medial branch blocks. And what we do is we identify, looking at the MRI, I'll see whether or not there's joints that have arthritic changes that are occurring there. And we, based on exam, we'll see where the level of your pain is at. And so let's say your pain is just in the low back, it's not going down the legs. So that tells me that it's likely coming from this area if it's low. And so we do a diagnostic test where I block the individual nerves that go to these joints here in the back. And if you get significant improvement of your pain for 12 hours or the length of the local anesthetic that we use, then you can have that ablation performed, which is long-term treatment. So you can get 6 months to a year, even longer treatment relief until the nerves grow back again. That's just for your facet joints. Now, if you go further down, let's say you have low back and buttock pain, your sacroiliac joints, which are just a little bit lower, is a common source for pain too. So these joints here can cause pain in your butt, down the side of the hip, and even occasionally in the groin, because it does come out in the front too. Your SI joint comes on the front. So we can do injections, steroid injections into the joint itself, as well as other nerve options that we can try, ablation and things like that for SI joint. Also, I can do a SI fusion. So if, let's say, we found out that the SI joint is causing you discomfort, we can do a simple injection percutaneously with rods, where we put rods along the side of the hip here and put them through into the sacrum. So we fixated the joint space. That joint only moves about 3 to 4 millimeters, but that's enough to cause significant pain. And so a percutaneous SI joint fusion is something that we offer as well for patients. The incisions, again, are tiny, the size of the pencil or the pen that I'm using here. And we place the screws right across here, all done with minimally invasive techniques. So that's something also that can be done for SI joint problems.
All right, let's move to this question, which is about medications. Amy's wondering, what type of medications do you give or prescribe for nerve pain?
Great. So nerve pain has its own class of medications that work specifically for nerve pain. The idea of why the nerve is irritated, or the concept of why a nerve is irritated, is usually the end or the outside part of the axon or the outside part of the nerve is somehow damaged. You can have that as a peripheral neuropathy, or you can have damage to the nerve from trauma. The treatment medication-wise is something that stabilizes the membrane of that nerve. So certain medications that are very commonly used are gabapentin and pregabalin. We also use other different classes of medications, such as SNRIs like Cymbalta or duloxetine. We use other, a whole host of different nerve medications, the amitriptylines and nortriptyline, but there's tons of different medications that are specifically tailored for nerve pain. There's also other sources of pain when you have nerve pain, so using anti-inflammatory medicines in combination with that can help. But we try for nerve pain not to use opiate medications, because studies have shown that those have not helped for medical treatment for nerve pain.
All right. And, here's a good question that was submitted. Wondering about, what are your current wait times to see you? Pat is wondering how soon she can see you. Or he can see you. Sorry, Pat.
Yeah, so the fortunate thing is we started the center here last year, and we are ramping up at great speed, but we still are trying to get patients in within the week if we can. I think, and correct me if I'm wrong, Brittany, but Monday? Okay.
Monday's our first establishment.
Okay, so Monday, So we have just, you can come and see us on Monday. So that will be an easy, just call us at the center and we'll get you in. We try, like I said, we try to get everybody in within the week of consultation. Our procedures that we do, I have a day of, right now, we have a day of OR a week. Sometimes it's more, sometimes it's less, but we try to get the procedures done within the week, at most 2 weeks from seeing us to get the procedures done.
Tim asked this question, says, I use my hands a lot to bind paper and work with several pounds of paper a day. It hurts just zipping up a coat or sweatshirt and even cutting food with a fork and knife. Any suggestions to help there?
So the hand, lots of different things go on in the hand. So that's, unless we see you and we can determine exactly like where in your hand it hurts, there's multiple different things that can be done. A lot of patients tend to have a lot of thumb pain, and there's the CMC joint that can be affected for thumb pain that we can inject into. Some people have decurvians, tenosynovitis, which can hurt more along this lower base of your hand. We could do injections there. Some people have a hand pain, like I said, from carpal tunnel. But all of these joints and ligaments and tendons and things in our hand can be addressed. So there's options available for people that have hand pain. The other thing I forgot to mention was we utilize a lot of our other specialties. So if there's something that I'm not an expert in, like, let's say the digits. So we do digit injections, but let's say the distal tips of the digits is something I don't do. We have our hand surgeons that are hand specialists. We have ortho, knee, hip, foot, all the different places that I can send patients to. And even for spine. So let's say we see you and you have significant motor deficits, like a weakness, significant loss of sensation, or bladder bowel stuff going on. Those are not patients that I need to see. That's a surgical option. That's something that needs to be straight to our neurosurgeon. So I think of myself as, in generalized terms, like a cardiologist, in the sense that if a primary care doctor sees a patient that has high blood pressure, they're not going to send directly to the cardiothoracic surgeon for a triple bypass. They're going to send the cardiologist, and the cardiologist is going to work them up and try medications or maybe interventions, things like that they want to do. And then if that's not working, they'll send off to the kind of the higher level, bigger surgical options that are there. And that's kind of where I fit into the spectrum of pain. We try to get pain treated, and the studies have shown that the faster you get to see someone for addressing your pain, the easier it is to get rid of. So if you sit on it for years, that's harder to get rid of. So we try to tell our primary care doctors or our referrals to try to get us in within 3 weeks of seeing, like, let's say you have back pain and you see your primary care doctor, you go to the urgent care center. We try to get those patients in within 3 weeks. So try your conservative thing first, try your medications, try your rest, try your physical therapy. And if you're not getting better within 3 to 4 weeks, it's time to see a specialist. And that's where we come in. And then if we see something that we think that, wait, this person needs something even more, that's where we go and move on to our other specialists that can do bigger, more invasive surgeries. And the thing about what we do, we try to avoid large surgeries if we can. If there's an indication, definitely. But minimally invasive treatments is kind of the thing of the future. Everything is being done with less trauma to the body, less recovery time, and the same outcomes. So why do the latter instead of getting the same kind of results with something small? But yeah, so for the hand pain, definitely different things that we can do. And if we can't figure it out, then I send to the person, the hand specialist, that might have the surgical options.
All right, I think we've gotten through all of the questions we had submitted for today. Dr. Patel, thank you so much. Anything else before we go?
No, I just thank everyone for joining us. I'm very happy I got some questions. There's so many things running through my head about, different options of treatments, that we do that wasn't covered here. So, my takeaway here for all of you guys that joined is, if you have pain, it could be from top to bottom, anywhere. Come and see us. The least that we can do is give a consultation, give you some advice. If I can't help you directly, that I could send you to somebody that might be able to help you. But, we take all insurances except I think a few, but you can just call and see. We don't need a referral from your primary to come and see us. So you could just, call and say, hey, I got this problem. I want to come and see you. And our wait times are short, so we can get you in quickly. And like I said, try to get in. If you have new pain, come and see us first. And that way we can kind of address it and take care of it before it becomes a chronic neuroplastic condition that's stuck in the central nervous system. And, we do have options for that too. We use pain psychology heavily, which has been shown with significant evidence to improve chronic pain sufferers. And that's something we really try to promote too here.
All right. Thank you, Dr. Patel.
Thank you.